like to thank the organizers for the opportunity to be here. Not moving? Can I do it from my laptop directly? It's not moving. Okay. Yeah. So, glaucoma at birth accounts for about 1 in 10,000 live births. It is rare for an ophthalmologist to see the entire spectrum, and that too all large numbers. Different people have classified congenital glaucomas differently, but if you look at it, it's broadly developmental glaucomas, and it includes the primary congenital variety where there is no associated ocular or systemic anomaly. Then you have the developmental glaucomas where there is an associated ocular or systemic anomaly. In primary congenital glaucoma, the maldevelopment of the trabecular meshwork accounts for the rise in intraocular pressure. Based on a modification of Quitko and Morin, the Apicenter group in 1984 had described the clinical features and classification to be followed in India, which gave us an idea to the management and also a guide to the prognosis. This included the newborn variety, which was present from birth to 1 year, and the classical triad of blepharospasm, photophobia, and watering was absent. Then you had the infantile variety from 4 weeks to 3 years of age. The classical triad of blepharospasm, photophobia, and watering was present. And then you had the juvenile type, which was not unlike the open-angle glaucoma type. And so this is the front-on view of the eye of a newborn. You find that the mesodermal tissue adjacent to the pupil is not developed all the way up to the periphery, creating black triangles surrounded by vascular pillars where iridial blood vessels actually tend to run. These are again to show you different forms of developmental glaucoma: Sturge-Weber, Neves-Ophota, Axenfeld-Rieger syndrome, aniridia, Peters, and various forms of iridocorneal endothelial syndromes. Gonioscopically, in congenital glaucoma, there are two variants that we see. There is a high insertion of the iris, and the other part is there can be an incomplete separation of the iris. Primary congenital glaucoma is a surgical entity. Medical treatment has a role only till the time you're able to prepare the child for surgery, or if the intraocular pressure increases after the surgery has been done. Early surgery is desirable before the Schlemm's canal is obliterated. The corneal clarity is getting affected, because if the intraocular pressure increases, the optic nerve is also going to get changes. We have several surgical options. Let's look at them individually. Goniotomy was first introduced by De Vincentis, but is attributed to Barkens because he combined it with the use of gonio lenses. The procedure over the years has remained the same, where you enter the anterior chamber through a corneal incision, go all the way up to the opposite end, and you slice through the iris tissue that you see here, 100 to 110 degrees. The use of, so the success rate was found to be very effective in about 80% of cases. Even Schaeffer's success rates were very good. Surprisingly, the results of goniotomy are not good when the glaucoma surgery is done within a month of birth or after 2 years. Clear cornea is one of the prerequisites to doing a good goniotomy. The use of viscoelastics to facilitate a safe passage across the anterior chamber, gonio lenses, and surgical microscopes have enhanced surgical outcomes. You can use pilocarpine before and after the surgery. Even an endoscopic goniotomy has now been tried. But I think the biggest limitation in Indian scenario is the fact that most of our patients present with cloudy corneas, and that decreases the success rate or the viability of doing a good goniotomy. Trabeculectomy was first described by Burian, where he through a radial incision, de-roofed Schlemm's canal using a trabecular tome. Harms added to this by creating a superficial triangular flap and then de-roofing Schlemm's canal. The use of pilocarpine before and after helped increase the success of the surgery. Even sutures have been tried to de-roof Schlem's canal. The advantage of the trabeculotomy ab externo is that it can be done even in the presence of a corneal opacity. Trabeculectomy has also been tried. The conventional trabeculectomy that we do combined with mitomycin, releasable sutures have all been tried in these glaucomas. People have tried to combine trabeculotomy where you have the advantage of getting the aqueous in the anterior chamber to gain access to the Schlem's canal, and have a backup by doing a trabeculectomy where you get the aqueous to get into the subconjunctival space. So you try to create two outflow passages for the aqueous to flow out. Trabeculotomy and trabeculectomy ab externo combined were first described in an eye where the goniotomy had failed. The RP Center group since 1970 had been trying out various surgical procedures and were not very happy with the outcomes they were getting. The initial results with goniotomy, goniopuncture, sheaths and all were very good in the initial post-op period, but then the intraocular pressures were beginning to increase. And that's when they even looked at trabeculectomy. Till the time they combined the trabeculotomy ab externo with the trabeculectomy. So here you can see they've raised a triangular flap, a deep scleral block is marked, and just anterior to the scleral spur is Schlem's canal, which can actually be cannulated with the Harm's trabeculotome. So what they observed was in 19 eyes that 17 eyes the intraocular pressure was well controlled for a period of 2 years without any medication, leading them to conclude that the combined procedure was safe and effective in controlling intraocular pressure in congenital glaucoma. Since then, more or less, the trabeculotomy ab externo with trabeculectomy has been the norm for primary congenital glaucoma in India. Dr. Mandal, the LV Prasad people have only popularized the combined procedure over the years. We recently published in Eye the long-term outcome of a single surgeon where we took 230 eyes from 121 patients who had been followed up for a minimum period of 20 years. 172 eyes had newborn glaucoma and 58 had infantile glaucoma. And success was achieved in at least 73% of the eyes, with additional surgical intervention required only in about 18% of the eyes at last follow-up of about a mean follow-up of 29 years. We also found that the probability of success IOP-wise was 95% till 25 years, 90% at 27 years, going down to 68% at 30 years respectively. Visual acuity is a very important criteria because Anderson in the earlier part of the century had said that children with congenital glaucoma can be safely put in a blind institution by the time they reach adolescence. This study shows the long-term outcome of the combined procedure, implying that less than 30% of patients had a vision of less than 30% had a vision less than 20 by 200, and if we use the current WHO criteria, only 20 patients at the last visit, about 12% had severe visual impairment and were functionally blind. So that was the extent to what the combined procedure outcome were. Aqueous drainage devices have a definite role when your primary surgery has failed. Maybe a trabeculectomy has also failed. The advantage, aqueous drainage implants have fared better as compared to trabeculectomy with mitomycin as far as IOP lowering is concerned, but these have all, the drainage implants have also required more reoperations for surgical complications. A wide variety of choices is available, but it all boils down to the experience of the surgeon, the type of glaucoma, and the socio-economic environment. Commonly, the Ahmed, the Barwelt, and the Indian version, the Adi, are commonly being used. But then, many of these implants require resurgery for the complications that they produce, like corneal decompensation, tube erosion, and migration. In fact, in children, hypotony, tube exposure, motility problems, and bleb encapsulation are much more common as compared to adult eyes. Destructive procedures are actually reserved for situations where keep them for refractory pediatric glaucomas where eyes don't respond. The issue here is that the titration of the intraocular pressure is difficult, and also because the ciliary epithelium has the ability to regenerate, so multiple treatment sessions can be required. Cyclodestruction is difficult to do when the transscleral diode laser is commonly used and is difficult to do, particularly in eyes which have thin sclera. There's always a fear of creating a perforation. And over a period of time, these scleral laser application spots tend to thin out further. So these are the surgical operations. I've purposely missed out on non-penetrating surgeries because they do not provide adequate lowering of intraocular pressure. We are actually aiming for pressures close to 10 millimeters of mercury in these children for their lifetime. Operating in children is a challenge by itself because of the ophthalmic eye. The sclera is thin and the limbus is enlarged, and as a result of that, the anatomical landmarks are all distorted. They are prone to faster healing, and if a previous surgery has been done, that also needs to be kept in mind. Examining children is extremely difficult, and therefore the outcome can at times be difficult to assess. A ophthalmic eye is, they have low scleral rigidity, and they're predisposed to complications of a low IOP like a hypotenuse maculopathy, choroidal effusion, suprachoroidal hemorrhages. Procedure specific wise, in Indian eyes, a goniotomy is difficult to perform usually because many of them present with cloudy corneas. The glaucoma, when they present, is fairly advanced and because of their late presentation. In our study, we had 71% of eyes which presented with corneal clouding. Trabeculectomy, and therefore the same would apply to the combined procedure. The anatomical landmarks in the ophthalmic eye are difficult. Raising the superficial triangular flap, whether triangular or rectangular, is difficult, and because of the thin sclera, you often tend to have a cheese wiring effect as you're suturing along. These eyes have exaggerated healing response, and they are prone to, if you've used mitomycin, you'll find that the blebs tend to thin out and have a tendency to leak over time. Same applies here. The difficulty to this procedure actually is that sometimes it is difficult to identify the Schlemm's canal. This is a child. Remember, it's not glaucoma drainage, but aqueous drainage devices. Patient presented with 2 surgeries done earlier, superior nasal, inferior temporal, inferior nasal staphylomas. A first tube was done, followed by a second tube, as you see here. So glaucoma accounts for 1 in 10,000 live births, and average life expectancy is 90 years, so you actually need 3 generations of ophthalmologists to take care of one child. Glaucoma surgery in pediatric eyes is challenging, and remember that congenital glaucoma is a surgical disease. The first surgery usually carries the best success rate. Trabeculectomy ab externo with trabeculotomy with trabeculectomy is the first preferred choice, and then these are additional choices that you could look for repeat surgeries. It doesn't end with a good surgery. Children need to be followed up and treated vigorously for simple things like an amblyopia. Thank you very much.